So welcome to the critical thinking and nursing process of the high-risk antepartum client and family. We've done now the normal, now we're going to the high-risk lectures. Most women who enter pregnancy in good health do expect to complete a pregnancy and birth without complications. But sometimes, however, unexpected deviations or complications from the course of normal pregnancy do occur, which place them at a severe burden on a woman and her family and her healthcare providers. And then we're going to talk about in this lecture the leading complications that are related to pregnancy. And we're going to cover all of the complications in the next slides to come. So we're going to start off with, make sure, okay. Okay, so we've got some goals and objectives, and we are going to describe the care of high-risk antepartum patients with hyperemesis gravidarum, with molar pregnancy, ectopics, placenta previas, abruptios, premature rupture of membranes, preterm labor, hypertension, gestational diabetes. Those are our objectives. You're able to design a plan of care for a high-risk antepartum patient, and then our goal is at the end of this content that the students, all of you, will be able to apply the concepts of a high-risk pregnancy and develop a plan of care for a high-risk antepartum patient. Of course, we can't start without adding contributors to a high-risk pregnancy, okay? And there's many influences that affect the outcome of a pregnancy. From health to nutrition, to motivation, to family, to education. There's many contributors that add to the outcome of this pregnancy, okay? Is mom acquiring an induced now condition because now she's pregnant? Family, support, stressors, motivation. Is this a wanted pregnancy? Is this an unwanted pregnancy? Her health is very important. Even socioeconomic status. So there's a web, and of course it goes everywhere. And it can affect, back and forth, all the influences. We're going to talk about these as we go along here. Give me a hard time to move my slides, so we're going to okay. So first content we're going to talk about is hyperemesis gravidarum. Okay, now what is hyperemesis gravidarum? It is excessive vomiting in the first trimester that leads to dehydration, starvation, and ultimately death of the mom and death of the fetus. Okay, hyperemesis gravidarum causes our increase levels of HCG and estrogen. Okay, and a lot of times this is the biggest cause of why moms get hyperemesis gravidarum. They just have nausea and vomiting all of the time during their pregnancy. Okay, high levels of HCG, human chorionic gonadotropin, and high levels of estrogen. And this usually causes for a weight loss of at least 5%. This is hyperemesis gravidarum. What do we do with these moms that can't tolerate any food in their system and they're having a growing baby in utero? Well, they get hospitalized, and this is beyond the morning sickness of 12 weeks. Sometimes this goes beyond that. Okay. For hospitalized, they're going to be NPO until this dehydration is resolved, at least for the first 48 hours. They're going to get IV hydration, and then they're going to go on a gradual diet, which will be clear, full, soft, and then obviously regular, and TPN if necessary. And usually we will give them vitamin B6, B as in boy, B6, Unisum, which is a nighttime sleeping aid and it's prevention of motion sickness. They'll get some Reglan. They'll get some Phenergan. Okay. And we encourage, and we want to make sure that we include it in their management is we encourage them small, frequent meals or snacks. And these moms usually eat at night. They always say that it's better to eat at night when they've been so nauseous. Usually they tolerate food, and if it's any, it's going to be at night. Now, our nursing responsibilities for this mom that has hyperemesis gravidarum is still strict I's and O's and emotional support because they have a growing baby in utero. So you always want to make sure that you have fetal well-being with these moms, okay? Sometimes they'll come into the hospital early, like maybe they're only 10 or 11 weeks. And remember what we said, an ultrasound, we can get the heartbeat, but by Doppler, it starts usually by 10 to 12 weeks. So if you don't hear a heartbeat by Doppler, you can do an ultrasound. You can do an ultrasound at the bedside to get the baby's heartbeat. You always have to make sure you've got good fetal well-being, okay? And also don't forget the family should be included in the nursing responsibilities of this mom, okay? So hydatiform mole. So this is what we call a molar pregnancy. Remember, and when we talked our first lecture, which was the normal antepartum lecture, and we talked about HCG levels, and we said that sometimes there is a molar pregnancy, but there is no fetus and there is no heartbeat, okay? It's just a challenge, okay? It's a disease of the placenta. Well, here we are, and that's why we said that pregnancy test, a positive pregnancy test, is really not a positive sign of pregnancy because it could be something else. This is what we were talking about, hydatiform mole. So it's a molar pregnancy. This is a disease of the placenta, okay? This is abnormal formation of the placenta into fluid-filled grape-like clusters. What you're going to see is still, body's going to mimic, yes, that there is a pregnancy. So there's an increase in HCH levels. And the rationale for that is because HCH, that hormone, human chorionic gonadotropin, this hormone is producing the thromboblast cells, okay? And you spell trophoblast as Trophoblast. Okay? HCH is producing the trophoblast cells, and these are abnormal trophoblast cells that are growing so rapidly that the uterus tends to expand faster than normal, okay? And then, of course, there is this abnormal proliferative tissue. Everything is happening in the placenta. Okay, usually 1 to 1,000 pregnancies. Women at risk tend to be those women that have had challenges with ovulation, and then early teens and advanced maternal age, and we're talking over 40, when there's a pregnancy and it's over 40. And I want to show you the placenta, okay, and what the placenta looks like. Okay, you see those little fluid-filled grape-like clusters. This is that abnormal formation of the placenta into fluid-filled grape-like clusters. Look at the placenta with little, and then under a microscope, this is what you see, the little grape-like clusters. Okay, so what are signs and symptoms? This is a placenta, but it's just growing. It's growing and it's growing. So there is going to usually be a spontaneous abortion at about 12 to 16 weeks. Okay, usually. That is the usual. About 12 to 16 weeks. Okay, because mom will start spotting, vaginal bleeding that she'll start spotting. She'll have this brownish looking prune juice color. Okay, she'll have that passage of hydropic vessels, little vesicles, like passing a grape. She's got enlargement, uterine enlargement greater than expected gestational age, so she's large for dates. It feels doughy. There's an absence of fetal heart tones, so there's no activity noted. She'll have hyperemesis gravidarum, and she'll also have this hypertension that it's pregnancy induced. So this probably what we call gestational hypertension. Maybe she's never been hypertensive and now she is. So we would call it gestational hypertension. So this is a pregnancy induced hypertension. So gestational hypertension in the second trimester. And any symptoms of hypertension of mom that has never been hypertensive and she has symptoms now of hypertension less than 20 weeks, usually it's a red flag. Dig in a little deeper because something is not right, because it's not normal all of a sudden now you're pregnant and now you've got hypertension. We might be thinking and saying to ourselves, we have to watch her because it could be a molar pregnancy. So that would be a red flag. Okay. How do we manage? Well, we're going to see a molar pregnancy. Obviously, this disease of the placenta, we're going to see this in ultrasound. Okay? It's going to show the presence of a molar pregnancy. So what we're going to do is we're going to evacuate the mole. So we're going to do a DNC. A DNC is we're going to remove the placental fragments. Okay? We're going to do a biopsy, a tissue biopsy for malignancy. We're going to do a type and cross for possible transfusion. And lots of emotional support and bereavement care. Because now she thought she was pregnant. Now it's the placenta. There is no fetus. There is no heartbeat. It's a disease of the placenta, but she thought she was pregnant. Lots of emotional support. There's also the possibility that this can develop because remember, these are abnormal proliferative tissue, okay? Trophoblastic cells that are reproducing. So there is a possibility that this can develop into cancer, okay? She's got, now we're going to have to tell her she's going to follow up for at least 1 year following. You're going to stress the follow-up care. She has to take contraception. There could be religious, there could be ethical issues with this, so that causes a lot of stress. Okay. Now, what does a follow-up for at least 1 year look like? She's got to be on contraception for at least a year. We've got to heal this uterus because this placenta is in this uterus. We have to clean it out. We have to make sure that there's no HCG detected, okay, that the body's not detecting any pregnancy. We have to clear this out. This uterus needs to heal. So we need to make sure that she takes contraception for at least a year. So how do we follow up? We're going to do beta. Remember, that was the blood test. Beta HCG levels weekly for 3 weeks. Then we're going to do beta HCG levels monthly for the next 6 to 12 months. Okay? And what we want to see is decrease beta HCG levels to the point that there's none detected. Now, if we continue to have high beta HCG levels, that may indicate trophoblastic tissue, which is obviously malignant transformation. And what we're going to do again is we're going to repeat and do a DNC. We're going to do a tissue biopsy for malignancy. She might have to get on chemo. She, sometimes sometimes a hysterectomy to decrease that percentage now of choriocarcinoma. Just about a 20% population. So usually women do good. And once you clear out that uterus, there's no more HCG detected. But sometimes when there is, then we have to further clean out the uterus, make sure that there is no malignant transformation. So DNC, biopsy for tissue biopsy for malignancy, sometimes chemo, and sometimes a hysterectomy to decrease that percentage of choriocarcinoma. And then throughout, because it'll be a follow-up for a year, and then throughout, we usually check about 2 times a chest x-ray because 75% of the time the lungs are the site of the metastasis. So we'll check her lungs usually at the beginning of as soon as mom is detected she's got the molar pregnancy, and then usually at the end. And sometimes you'll see that they'll do in the middle. So 2 to 3 different times chest x-ray. This was molar pregnancy. We're going to talk about abortions now, which a lot of times they'll say abortion, they'll say miscarriage. Okay. Usually the word is used to mean the same. Okay. It's intertwined, abortion and miscarriage. It just miscarriage seems a whole less harsh word. So abortion, the expulsion of the fetus prior to viability, which is 20 weeks gestation. Okay. 15%, I just want to just kind of give you this information that 15% of all pregnancies, and these are statistics, usually end in a miscarriage. And remember, when we talk about miscarriage, we talk about abortion and miscarriage. Both words kind of use this, use the same. So usually 15% of all pregnancies end in a miscarriage, and that's because it's a rehearsal for the uterus. Okay. Now, 80% of those miscarriages are usually when mom, okay, when the patient, when that pregnant mom is less than 12 weeks pregnant, so very early on. Now, there are 2 types of abortions. There is a spontaneous abortion, which occurs naturally, okay, or like, anybody would say a spontaneous miscarriage, okay, occurs naturally. It just happened, mom started bleeding. And we have those induced abortions, and that's a result of artificial or mechanical intervention. Okay. And we're going to talk about different types of spontaneous abortions. Okay? There is a threatened abortion, which there's slight spotting. There's no cervical dilation in a threatened abortion. Okay. Then there's imminent abortion. This is also called inevitable. This is the point of no return. This is happening. Okay, this is where that cervix dilates and it can't be prevented and it can't be stopped. And this is imminent abortion. Okay, then there are 2 types. If everything is coming out of the uterus, and there's 2 types. There's a complete and there's an incomplete. So the complete is usually heavy bleeding. You've got fetal fetus, you've got the tissues, it's completely expelled from the uterus. Everything is completely expelled. And then when something is left behind and it's not, and we'll do an ultrasound and we do see some fragments still in the uterus, that's an incomplete abortion. Okay. Now, missed AB, sometimes we call abortions for short on the charts AB. A missed AB is no bleeding or just very slight spotting. In a missed AB, there is no cervical dilation, but the product of conception remains in utero after that fetus dies. Okay, remains in utero after that fetus dies. So when you go into the healthcare provider's office and you're going for your prenatal visit and they're checking with the Doppler, there is no heartbeat. So the fetus is, it's a demise, okay, in utero. So the fetus has died in utero. Okay, that's a missed AB. So you don't have to necessarily see spotting or very, very slight spotting. And then no cervical dilation either. Now, habitual abortion is 3 or more losses for no known cause. Now, usually abortions are usually related to hypertension or abruptio placenta. And there's some pictures. Now, these pictures I want to say, and I want to highlight this, and I want to say that a lot of these are copyrighted and it's only for sample use to show you during lecture. But because we're in virtual and this is a contingency plan that we have, teaching remote, I'm just letting you know that all of these pictures are copyrighted. That some that I sent to you that I usually only put in the classroom do say sample only copyright. So I just want to make that announcement, okay? That this is only to show you for lecture. These are sample ones that are given to me to show to the class for lectures, okay? So this is a miscarriage. This is a threatened AB. Okay, again, there's slight spotting. There's no cervical dilation. Then we have the miscarriage. You see how it's abortion and miscarriage is kind of intertwined. This is inevitable. Okay, this is the imminent abortion. This is when the cervix dilates and everything is coming out. It can't be prevented. It can't be stopped. Okay, fetus, the tissue that's completely expelled from the uterus. Everything is coming out. And then there's the incomplete. Okay, where everything is coming out, but there's something left behind. Okay, maybe there's still up here, maybe there's still some tissue left, maybe there's still pieces of placenta left. Okay, everything, something has stayed, and that's the incomplete. And then we're going to talk about, signs and symptoms of abortions. Okay, well, there is unexplained vaginal bleeding. Okay, passage of tissue of the product of conception. There is cramping, usually in the lower abdomen. And moms will complain of a backache. Okay, also. So they know they're not feeling well. Something's going on. A backache. Be signs and symptoms also of infection, maybe a fever, malaise, thirsty, they're nauseous, they're vomiting. Those are all signs and symptoms. So when they first call in to the healthcare provider's office, to the clinic where the OB healthcare provider is taking care of them, you want to make sure that, you do a little assessment. Okay, so you want to make sure, again, the first day of their last menstrual period was. You want to make sure their GMP goes back to, again, their GMP, gravida over parity. So we're going to make sure gravida over parity. So we need to know TPAL, right? Those, remember, it's a 5-digit. The first one is gravida, and then you want to know parity. So full-term preemies, abortions, and live-in. Okay, so the 4 numbers. G over P. Vital signs. You're going to do, take their vital signs. You want to make sure if she's taking her pulse at home. And then when she comes in, you're going to do that assessment on her. Okay. So they call, we want to ask also always for her day of her last menstrual period and her GMP. And when she comes in, and we want to ask her also the amount, the color of the bleeding, if she's counting her pads to let us know. The way we know is she really having heavy bleeding or not. And then her pain and her comfort. So her cramps, her contractions. And then when she does come in, we're going to do her assessment, obviously, and we're going to ask her this again. Her last menstrual period, her GMP, her vital signs. We're going to assess the cervix for dilation. We're going to look at the amount and the color of bleeding. She's going to tell us, how many pads she's changed. And then we're going to obviously ask her about pain and comfort. So does she have her cramps, her contractions? And then we start with the management. Okay, so we're going to do ultrasound and make sure that there's fetal heart tones. This is how we're going to know. Okay, fetal heart tones are very important. We'll draw lab work. So we need to make sure we have H&H, CBC, a type and cross, a beta HCG, because we're going to compare it to the first time that she was here, okay, to see if those levels are coming down. Beta HCG and progesterone. Remember, progesterone holds that pregnancy together, right? It allows for that uterus not to be contracting, okay? So we need to make sure that her progesterone levels are not low. Bed rest. She wants to abstain from sexual intercourse. And if we need to give her an IV, we'll give her an IV. Okay, if she needs to be transfused, she will be transfused. Okay. We'll have to do a DNC. Okay. Her cervix is dilated. A curette is inserted to scrape the uterine walls, and of course we're going to remove that uterine content. Okay, and you will see that sometimes if she miscarried beyond 12 weeks, so she was after 12 weeks pregnant, she can be induced with oxytocin and prostaglandins. Okay. Also, again, lots of emotional support and bereavement care. There's a lot of feelings of guilt. Did I do something that I shouldn't have done? Sometimes there's feelings of ambivalence. Sometimes there's feelings of punishment. I knew I shouldn't have done this. I deserve it. So lots of emotional support because now mom has lost her pregnancy. And then we go on to move on to our next topic here, which is ectopic pregnancy. Okay. Usually accounts for 2% of all pregnancies in the US. It is a leading cause of first trimester maternal deaths because this little sac right here can rupture, and it's a leading cause of infertility. So what is an ectopic pregnancy? And a lot of you are listening to this, and maybe you have family members, or you've known somebody that has had an ectopic pregnancy. And I know from the other topic that we talked about, you've probably known somebody that has had a miscarriage before. So ectopic pregnancy, an implantation of the blastocyte in a site other than the endometrial lining of the uterus. So most common site is in the fallopian tubes. So in this picture right here, okay, obviously, every time I do this, it wants to move. So cervix, okay, uterus, fallopian tube, and this is the ampulla of the fallopian tube. Okay, and this is your most common site for a tubal pregnancy, an ectopic pregnancy, which is a tubal pregnancy, is in the fallopian tube. But this tube is really thin, okay? Really, really thin. Look at your little pinky. Look at your little pinky finger. Very, very thin. Sometimes thinner than your pinky finger, okay? It's painful because that little baby can't grow in such a tiny little space, and that's why it causes so much pain. So signs and symptoms. Usually ectopics are discovered by the 8th week of pregnancy because there's so much pain. Mama's going to double over either to the right or to the left side, depending on which tube, okay, which fallopian tube, and she's going to be doubled over in pain. I mean, just excruciating. So usually it's discovered by the 8th week of pregnancy. And hopefully she's going to say something where it's going to be unruptured and we can go ahead and take care of it. Usually that's the case. Risk factors before we continue on with signs and symptoms are acquired sexually transmitted diseases that she's had a history of, pelvic inflammatory disease that she has a history of, or if she has a history of using an intrauterine device, okay, an IUD, an intrauterine device. And remember again that usually it's discovered by the 8th week of pregnancy. And remember that we said the gestational sac is visible at about 5 to 6 weeks via a vaginal ultrasound. So signs and symptoms, there's usually going to be abdominal pain, sometimes early on as soon as this patient is pregnant. Okay, as soon as this patient is pregnant, usually sometimes there's abdominal pain as early as 5 to 6 weeks when she first discovers that she's pregnant. Okay, signs and symptoms. So there's vaginal bleeding, there's lower abdominal pain, usually it's very sharp and it's one-sided. There could be fainting or dizziness, there could be hypovolemia, she could be having a rigid, tender abdomen, and on exam, there's a palpable mass, okay, with extreme pain. So she could be hypotensive, she could be tachy, she could be very pale, and this could lead to her hemorrhaging her being in shock, or even her having a peritonitis if it ruptures. What is the management and what are we going to do for mom? Well, we want to make sure, of course, what's going to happen here is that we're going to check for her H&H. Her leukocytes are going to be high. We have to check for her beta HCG levels as well. Okay, so a pelvic exam, okay, an ultrasound, and there could be a salpingostomy procedure. Now, this is when the sac right here, this is the ampulla. Okay, this is the ampulla right here. This is the most common. This is the ampulla right here. Little inflamed. It's got a little fetus right here. So if it's nice and unruptured, okay, we could do that surgical removal of one or both fallopian tubes. And this is what has been done forever and a day until wonderful IM methotrexate came to town about maybe 10, 12 years ago. And then we started to give IM methotrexate to these moms that still the little sac was unruptured. Okay. And then methotrexate is given IM. It's a 50 milligram IM. Therapeutic effect is it has the death of rapidly replicating cells, particularly those that are malignant. Okay. Still, to give IM methotrexate, again, the mass has to be unruptured. It has to be less than 3.5 centimeters in diameter. Okay. It just resolves the residual tissue, just resolves it. They do have to return weekly and could be up to 12 weeks to draw a beta HCG because that's the only way that we're going to know, okay, if the pregnancy is not present anymore. So we're going to do that, and then if we see that there's decreased beta HCG levels, we're going to also do an ultrasound. And again, that's so that we can detect that the pregnancy is not present and the tube is fully patent. Okay? There could be a little bit of bleeding after methotrexate, and it's normal. Okay? And we don't want moms, and this is something that we have to stress out to them, there's no alcohol and there's no NSAIDs taking. So please don't drink alcohol and don't take any NSAIDs, non-steroidal anti-inflammatory, like ibuprofen, which is an NSAID. Okay? While we're in the treatment of this IM methotrexate. Okay? We want to make sure that she does avoid becoming pregnant for at least 3 months so that this fallopian tube can heal. Okay? Something else we want to explain to moms about the IM methotrexate is that methotrexate decreases folate. Okay, folic acid decreases folate in the body. So she's going to want to take folic acid for several months before she conceives. Okay. And then we want to make sure that those levels of beta HCG are below at least 5,000, okay, in her beta HCG levels. So that's a little bit about IM methotrexate, which does work, and it does work well. And because most of the patients that we do see are unruptured. But then you've got those that, maybe have a high pain tolerance or it just happened. And by the time that they're doubled over with pain, they're calling 911. They're in lots of pain. They come in and this little sac right here, they have a ruptured ectopic pregnancy, okay? And then we'll either do the laparoscopy or the laparotomy, depending on the rupture, okay? The laparoscopy is the little keyhole incision in the abdomen. And what they do in the laparoscopy is they ligate the bleeding vessels and they're going to remove or they're going to repair the damaged fallopian tube. And in the laparotomy, it's an open abdomen, okay? So they're going to remove the embryo and they're going to repair the damage. And we are moving on to our next topic, which is placenta previa. That is a placenta implanted abnormally in the lower uterine segment. This is because this is the normal implantation of the placenta on the fundus, the top of the uterus. It is not normal for the placenta to implant in the lower uterine segment because all those little vessels attach to mama's endometrium in the uterus. When it's not, what happens? Your cervix is right there and absolutely big potential for hemorrhage. Okay? I love these visuals. These are usually Adam or the different sources of books. Love these pictures. There's 3 different types of placenta previa. Okay, 3 different types. There is type 1, and I don't know why it's like this. Type 1 is here, which is low laying. This is type 1, low laying. Type 2 is partial, which is marginal, which is partial. Okay, and type 3 is complete placenta previa. It's classified in 3 types depending on the degree to which the cervical os is covered by the placenta. Okay? So it's classified in 3 types depending on the degree to which the cervical os is covered by the placenta. Now, some predisposing factors of why placenta previa. Prior history of placenta previa, be multiple pregnancies, be a history of multiple births or closely spaced pregnancies, a prior uterine scar, okay, or a patient that's advanced maternal age. Okay, when we call it advanced maternal age, it used to always be over 35. Still over 35, but I just want to let you know the stats are we are seeing patients older than 35, closer to 40. Now, symptoms. It does have a painless, quiet onset of bright red vaginal bleeding. Painless. Okay, so her abdomen is still soft, her abdomen is still palpable, vital signs are stable, but she could be in hypovolemia. Okay, she could be in shock, she could be anemic, she could have an infection. Okay. Now, what are we going to do? Nursing responsibilities. Now, one thing I want to make sure that I highlight with bleeding, and I know we've said this in Skills Day. I know you've had your virtual sim, some of you that have been in OB virtual clinicals already, is that when there's bleeding, okay, bright red vaginal bleeding, there's a red flag. There are no internal monitors that we're putting on mom, and there are no vaginal exams, okay, because we don't know what's going on with that placenta and we can produce hemorrhaging, okay, or further agitate whatever is happening, okay, make mom worse. So no vaginal exams because we could produce hemorrhaging, no internal monitors, okay, and no Leopold maneuvers. That's when you have your 10 fingers and 2 hands, and you're doing the outline of where that baby's at. We're not doing all of that to that abdomen, okay? So what's the first thing that we're going to do for nursing responsibilities in the placenta previa? Obviously, vital signs, fetal heart tones, okay? External fetal heart tone monitors, okay? We're gonna go ahead and start an IV. It's going to be a 16-18 gauge IV. Okay, if that bleeding decreases, then we'll hep lock it. Okay. Yes, bed rest. At least she comes into the hospital at least for a good 48 to 72 hours. Okay. We're going to monitor blood loss, so we're going to monitor the pad count every hour on the hour. We're going to do perineal care, education, signs and symptoms of labor. Okay. Letting her know about her condition. We need to make sure we have current lab data. Okay, so blood loss, RH factor, coagulation profile, and again, lots of emotional support. Okay, now mom is bleeding. She thinks she's losing her pregnancy. She's overwhelmed. She's worried. Okay, she thought she was pregnant, all was good until she started bleeding. Okay, now a couple of things that I want to mention before we go to abruptio placenta is sometimes if the bleeding stops, okay, she'll be discharged home on bed rest and on home care. And then, of course, if this happens and she's discharged home, we'll do frequent labs, H&H, and we'll assessment of the fetal heart tones. Okay, if her bleeding stops, the goal is to discharge her home. And if her bleeding stops and she's discharged home and all is good in the world again, then 30 to 32 weeks we'll repeat an ultrasound. Always with reassuring fetal heart tones. Always need to make sure that we have reassuring fetal heart tones. And reassuring fetal heart tones is make sure that it's 110 to 160. Okay? If she comes in with placenta previa and she's after 36 weeks, we're going to keep her hospitalized. Okay? Because obviously we don't, if she's bleeding and it's placenta previa, we've done an ultrasound, we don't want her having a vaginal delivery because a placenta can never, ever, ever be delivered first. Baby has to be delivered first. So she will have a C-section. And if it's a complete previa, then it's an emergency C-section. Okay? And a big highlight is because we don't know if we're going to have to deliver mom or not. Okay? Anytime we think that delivery is going to be anticipated and mom is less than 34 weeks, we're going to give mom for baby betamethasone, which is the celestone, which is a steroid. Okay, the IM steroid given for fetal lung maturity. Okay, so just highlight that medication. Okay, because we're going to start to give examples of when we do give it. Okay, and again, like you've heard me say before, it is any time the delivery is anticipated. And if she's less than 34 weeks, we're going to give mom for baby the betamethasone, which is a celestone. Okay? Okay, we are moving to our next topic, which is abruptio placenta. Okay. Let's go here. Okay, so abruptio placenta. So this is a premature separation of the placenta. I love this picture because it shows the actual little capillaries. It shows the placenta. It shows a separation. See how these capillaries go into the uterine wall, okay, and attach to the uterine wall, and then you can see that separation, okay, of the placenta. So of course, immediately lack of oxygenation to that baby. Okay, mom is not giving what mama needs to give to that baby. So of course, you're going to see a decrease in heart rate. You're going to see D cells. You're going to see late D cells on the monitor. Okay, so I love this picture. So this is the area of detachment. But insist on moving forward. Obviously the placenta, your baby, and the uterine wall. We're going to talk a little bit about what placenta previa is. So it's a premature separation of the placenta. Usually these challenges with bleeding, like placenta previas and abruptio placentas, occur late in pregnancy. Okay, most of the time they occur late in pregnancy. It is placenta abruptio or abruptio placenta is a leading cause of perinatal death, depending on the extent of the detachment. There is blood loss. It could be there's a degree of DNC, coagulation defect. That we'll talk about DNC and we'll go back to, yes, causes could be abruptio placenta. The fetus prognosis depends on the extent of that placental separation and the degree of that fetal hypoxia and the birth of that fetus, how fast we can get that baby out. Okay, when this abruptio placenta happens and mom is in excruciating pain, because abruptio is painful, okay, is very painful. Placenta previa is painless. There is no pain, but abruptio placenta is painful. So it depends on how fast we can get this baby delivered when this separation happens. That's pretty much the fetal prognosis, what it depends on. Okay, extent of the placental separation and the degree of fetal hypoxia and the birth of that fetus. Now, symptoms, again, remember, patient arrives at the hospital and of course she's bleeding or she calls 911. They're going to do an IV access, okay, large gauge, 16 to 18 gauge needle. Remember from block 1 what's coming out, okay, so patient doesn't get hypovolemic. What's coming out must be replaced. So she'll get an IV access. We'll do an ultrasound because it's third trimester challenges. We'll do a biophysical profile. She'll get an H&H. She'll get a type and cross. And then again, severe pain. Okay, it's a stabbing pain. It's usually high up in the uterine fundus. It's dark venous blood. So there is vaginal bleeding, dark venous blood. Abdomen is rigid and hard. It is a sudden onset. There could be shock. Okay. Now, what are the predisposing factors? Predisposing factors, there's a couple of them. Hypertension in pregnancy because of the vasoconstriction, trauma to the abdomen, cigarette smoking, cocaine use. We always say that Pitocin is wonderful, but Pitocin is lethal. So induction via Pitocin, we're trying to have that uterus operate so fast and give us some, nice uniform contractions that placenta can prematurely separate. So again, we're giving the list of the predisposing factors: hypertension in pregnancy, trauma, cigarette smoking, cocaine use, induction via Pitocin, a term called chorioamniotitis. Chorioamniotitis is an infection of the fetal membrane and fluids. That's an infection that mom gets. She ruptures membranes. She'll get an infection, and that infection is called chorioamniotitis, infection of the fetal membranes and the fluid. Could be as simple as predisposing factor to placenta abruptio, could be as simple as a maternal malnutrition, sometimes uterine fibroids, okay? A short umbilical cord can be a predisposing factor as well, okay? Now, nursing responsibilities. This is an emergency when this happens, so we have to prepare mom for an emergency C-section. And then on the monitor, what are we going to see on the monitor when this is happening? What do we see on the monitor? We know it's something with the placenta, so we are going to have late decelerations, okay? This is fetal placental insufficiency. Late decelerations, what we're going to do is interventions, 10 liters of O2 via non-rebreather mask, okay? We're obviously going to monitor fetal heart tones. We're going to monitor blood pressure and heart rate every 15 minutes, okay? We're going to put her on the side laying position, hopefully left recumbent, left side. Heart is on the left side. We're going to do left side, if not right side, but we're all going to go for the left side to get more circulation to that baby. Okay, while we're preparing her for that emergency C-section. Monitor her blood loss. And of course, I'm sure at this point she's got her IV 16 to 18 gauge catheter. Okay. You start to put this all together when you learn the normals of your D cells. And now we're going into high risk. Now we put it together and we see the different situations where we do see these decelerations. Okay. Again, these are the pictures that I was talking to you about. I love these pictures, sample use. It's only for lecture. Okay, and they're obviously copyrighted. But this is a great picture, great visual. Okay, great visual for you. This is the blood from placenta abruptio. You could see this baby is cyanotic. Okay, this baby is blue, lack of oxygenation, the uterine wall, the detachment of the placenta when this baby's coming out. There's a lot of bleeding going on here. Okay, and then this is a great picture that I always like to show in class as well. This is when all is great and that's normal blood flow to the brain, great blood flow happening. See the little brains are the biggest. Okay, organ right here is the brain. And then all of a sudden you've got decreased blood flow from the placenta to the brain. And you could see not good. Okay, constriction, not good. Love this picture. And as you're studying, you can also see bleeding during late pregnancy. You could go through the algorithm. We're going to cover all of these. Okay, placenta previa abruptio, uterine rupture, DIC. As you're studying, you can go through the cascade. And that brings us to our next topic, which is premature rupture of membranes, which is PROM. Okay, this is rupture of amniotic sac and leakage beginning at 1 hour, okay, at least 1 hour before the onset of labor at any gestational age. Okay, but then we put a P in front of it for premature PROM, when preterm premature rupture of membranes, when the membranes rupture before 37 weeks. So when there's a preemie in utero and the membranes rupture at least an hour before the onset of labor, so before she's starting her contraction, before she is dilating, before her cervix is thinning, okay, 1 hour before that onset of labor, she ruptures membranes first. If she's full term, it's a PROM, but if she has a preemie in utero, that'll be a PPROM. Now, a little bit on the amniotic fluid function. We keep talking about amniotic fluid and that cushion that the baby's in utero. Amniotic fluid, just as a side note, so that you know, and that's important, is an amniotic fluid function. It cushions the fetus. It's a temperature regulator. It equalizes pressure and it allows a fetus to move. So baby is in that uterus, but inside that amniotic fluid sac, which cushions the fetus. There's a temperature regulator, equalizes pressure, and allows the fetus to move. Okay, nice environment in utero. When mom ruptures membranes, you've heard me say this, I believe, and also in Skills Day, we've got that big, and you've had a virtual for those of you that have had the virtuals already. There's a patient in there that might have ruptured membranes early. There is a diagnosis, there is a risk for infection when that sac is ruptured, and now that sac holds that baby in there, and now there's a leak, and now there's a great via for infection up to that baby. And I've got some great pictures to show you. So big risk for infection. Diagnosis rise, big risk for infection. We're also, again, because of that big risk for infection, we're going to limit vaginal exams. We're going to limit them to none. So, we've got to very, very much limit those exams that we're going to do. Even though I know there's sterile vaginal exams, we're going to limit them. And in the hospital, when this happens, and then when moms obviously come in and they're ruptured, We want to make sure we look at the fluid, that it's not smelling, that it's white, okay? Because if it's not white and it smells, then there's an infection. And that's where their chorioamnionitis comes in, okay? So we want to look at the fluid and we want to look at the fetal heart rate. Now, these are the pictures I wanted to show you before we keep going. Again, this is for sample use only for this lecture. It's copyrighted, but the little green dots are obviously the infection, okay? Now that mama is leaking, now there's bacteria coming in, so big risk for infection. And management. So we're going to hospitalize them, put them on bed rest. We could put them on Trendelenburg or not, depending. I'm going to put pressure off her bottom. Daily CBC. There's fetal well-being tests. There's the non-stress test. There's a biophysical profile. Okay, remember again, don't forget to know those. You need to know non-stress test, and you need to know biophysical profile. You know the non-stress test is the most widely applied technique for antepartum, evaluates the fetus. Remember, fetal heart tones with fetal movement, and the result needs to be reactive. And then the biophysical profile that's done by ultrasound, and they get 2 points each. The heart rate, the breathing, the body movement, the fetal tone, and then the amniotic fluid volume. Okay, so look those two up. Don't forget about those fetal well-being tests. And then we've got the medication that we need to give to mom for baby anytime we suspect that there could be an anticipated delivery. We're going to give her the betamethasone, which is a celestone, to mom for baby. And then, of course, antibiotics, because now she's in the hospital and she's ruptured membranes. We don't want her getting an infection. And remember when we talked about the LS ratio, now she's ruptured? Remember when we talked about the LS ratio? Well, then this comes to play. She comes in and she's in prom or she's in PPROM, and absolutely now she's dilating and the baby's going to be born, and let's say she's a PPROM, so the baby in utero is a preemie, and she's already ruptured. We're going to do an LS ratio to make sure those infant lungs are mature. Okay? We'll make sure that we do an LS ratio, and hopefully we get a 2-to-1, so that if this baby seems like it's going to have to get delivered sooner than later, we do an LS ratio on this baby. Okay? We usually keep moms that are ruptured in the hospital, but you will see that sometimes they can, very rare times, get discharged home on home management. I know it's in your book, but very rare times that they do get discharged home, because once that sac is ruptured, again, big risk for infection. But if they are discharged home, I want to make sure that you teach moms to take their temperature at the same time, 2 different times, okay, at the same time, okay? And if they get more than 100.4, they need to call their healthcare provider's office, okay, because then they've developed an infection, okay? If they are discharged home, usually we keep them in the hospital, okay, for proms and PPROMs. But very rare occasion if they're discharged home. Our next, some key points before we keep going. Okay, research has demonstrated that a gain of 48 hours to several days is the best outcome that can be expected with the use of tocolytics. Best reason to use tocolytic therapy is to achieve sufficient time to administer the steroid, okay, the glucocorticoids, which is your betamethasone, your celestone, in an effort to accelerate fetal lung maturity and reduce the severity of respiratory complications. And this is where, in our next, when we talk about preterm labor, we're going to talk about giving mom that tocolytic, giving mom that breathine, which we don't give past 48 hours, but we can give it immediately when mom comes in to stop her contractions, and we are gaining some time, okay, for that window of the betamethasone, so that baby has at least the 2, okay, IM injections, 24 hours before delivering. So if that's the case, we want to buy ourselves some time before we deliver that mom, so that that betamethasone gets to baby, okay? We're going to buy ourselves a little bit of time. If we have to do a tocolytic, we can do a tocolytic. We can give her the injection. We could do a day or 2 of the breathing to stop her contractions, to give this betamethasone immediately, so that we can stop this labor, get the baby still in utero, lungs for the fetal lung maturity, and then get this baby delivered. So that's what this means. Research has demonstrated that a gain of 48 to several days is the best outcome that can be expected with the use of tocolytics. We know the baby's going to be born. So, the baby wants to be born. Mom is having contractions. Stop the contractions. Immediately give her the betamethasone. Buy yourself a little bit of time before you take her back for delivery. Okay. Next. So stay tuned, because we will talk about that a little bit more. Premature dilation of the cervix. This was previously termed incompetent cervix, but we don't want to call our cervix as incompetent, so the term changed to premature dilation of the cervix. Okay, this is premature dilation associated with repeated second trimester spontaneous abortions. The cervix just dilates, which is not supposed to, unless you are in labor. And this is defined as painless during second trimester. Again, signs and symptoms are painless. They're bloodless, so it doesn't have to be blood. Second trimester abortions, minimal uterine contractions. Pelvic exam just shows the dilation, the effacement. Okay. So what is the etiology, history of maybe a previous cervical trauma, maybe lacerations during a previous childbirth, and increase again in maternal age? So management, what are we going to do for mom? Well, we're going to give them tocolytics prophylactically to inhibit the contractions. Okay? We're going to give them tocolytics prophylactically to inhibit contractions. Okay? We're going to do cervical cultures for GC, which is gonorrhea and chlamydia, and GBS, gram-beta strep. Okay? And then I put there that gonorrhea and chlamydia is done in the first trimester, and then GBS is done in your third. Okay, group B. Okay, group B, strep, okay, is done in your third trimester. So GBS is usually performed between 36 and 38 weeks. Testing before 36 really isn't accurate in predicting who will be carrying GBS at the time of labor. Okay. What we do for these moms that are now premature dilation of the cervix. Now the cervix is dilated, bed rest, because now you've got a baby in utero and you're completely dilated. Sometimes we have to put her on Trendelenburg. Okay. Sometimes they're in high-risk antepartum in the hospital for many, many weeks and weeks. Okay, depending on when this happens, especially if they're preterms. Okay. We do a cervical cerclage, and this is the cervical cerclage procedure, cerclage correction of the premature dilation of the cervix. Okay, and it's a ligature. Okay, it's a surgical reinforcement of the cervix with heavy ligature placed submucosally around the cervix to strengthen it. This is where this comes into play. Another picture here. Cross-section view of the cervix. Okay, so it's a surgical reinforcement of the cervix with heavy ligature placed submucosally around the cervix to strengthen it. Okay, That's your suture. Okay, Shredakar suture, and that's your cervical cerclage. Okay. Management, no sexual intercourse, no heavy lifting, no prolonged standing, more than 90 minutes, because it's you want to have pressure off your bottom. Okay. Then all would be good until mom goes into labor, and then we can take this ligature out so that she can labor and she can deliver. Or if it's a C-section, we'll do the same so we can deliver her baby via C-section. Okay, we're moving along to preterm labor. Okay, it's now you're seeing some different definitions in-house at the hospital where we could call late preterm 34 and a half to 36 and a half weeks. Okay, preterm labor, causes of preterm labor. Okay, it is the onset of labor between 20 and 37 completed weeks of gestation. Usually on the monitor, we will see more than 5 contractions in an hour. Okay. It's the preterm birth, so it's the birth that occurs before the completion of 37 weeks gestation. Causes, sometimes it could be multiple gestation, an infection, a urinary tract infection, rupture of membranes. Okay, rupture of membranes that due to the membranes rupturing, mom has an infection and now has caused her to go into preterm labor and have these contractions early, or an infection that mom had, like a UTI, that led her to rupture her membranes, and now she's got a preterm labor. Okay, so many more possible causes here. Too much fluid, extra babies, hormones, bacteria, the uterine clock. It just the uterus thinks that it's ready to be born. Okay, PPROM. Okay, sometimes the cervix just wants to dilate. Okay, so symptoms. And then again, I want to mention that with preterm labor, mom comes in and we don't know, we have to stop her contractions. Okay, so we don't get this baby born ahead of time because it's a preemie, it's preterm. So again, it's betamethasone or celestone to mom for baby is used in preterm labor to enhance that surfactant production. Okay, and fetal lung maturity if this fetus is less than 35 weeks. So again, another scenario where we're going to give anticipate delivery. As soon as mom comes in, we are giving her the betamethasone, okay, the celestone. And we're giving her tocolytics to stop her contractions. Buy yourself some time to make sure that we can give celestone to get to that baby, and buy yourself some time. If we can wait a week before that delivery happens, that's fantastic, because we've given this betamethasone to this baby. If we can only do it for a day or two, at least we were able to give it to mom for baby 24 hours before delivery. So symptoms, and this is what a lot of times we tell our patients, that's why prenatal care is so, so important. Because if they start, with cramping, menstrual-like cramping, they know what to expect. They know what things are not right. If they start with that headache, with that backache, usually that backache is dull and it's, low and dull backache. Okay, or spontaneous contractions. All of a sudden they start with contractions. None of this is normal. So a lot of times there's education that we tell mom ahead of time when she comes into the healthcare provider's office, that we tell her, if all of a sudden you're cramping, all of a sudden you have this dull, low backache, all of a sudden you have spontaneous contractions. That's preterm labor. You don't want that. That's not normal. You need to call. You need to come in to triage. Okay. Also, we tell her if you feel your abdomen is tightening, like pelvic pressure, your abdomen tightening, intermittent. It could be intermittent, it could be continuous. You have an increase or a change in vaginal discharge. Okay. They might be telling us this, but a lot of times this is also what we tell them as education when they come to the healthcare providers for prenatal screening, because we want to make sure that if they experience any of these, that they call. Now we're going to manage preterm labor is we want to make sure that we put them on bed rest. Okay, we're going to give them hydration and tocolytics. Okay, now terbutaline is not going to go over, we're not going to give that over 48 hours. Okay, if we need to turb them, we will. Okay, and then we'll switch them over to, we'll stop their contractions and switch them over to magnesium sulfate, okay, if need be, okay, if that's the case. And that's really, if terbutaline doesn't stop their contractions, they're going to go on magnesium sulfate. We're not going to keep them there for weeks like we used to. This is a change, a difference, a change with practice and management of preterm labor. Magnesium sulfate is there for about 24 to 48 hours that we're going to give IV mag to moms, and really is just to get her into that what we call the steroid window, getting her into being able to stop the contractions and being able to give the betamethasone to the baby to accelerate their fetal lung maturity, okay, accelerate that surfactant. What we are using magnesium sulfate for in preterm labor is for fetal neuroprotection, okay, to help minimize in preterms protection from cranial hemorrhaging, okay. So they'll come in. Some hospitals are not even using TURB that much anymore, but that's their choice. They can use it. They just won't use it for more than 2 days. They'll give them terbutaline to stop their contractions. If it doesn't stop, they'll get them into magnesium sulfate, or they'll put them and they'll give them magnesium sulfate first for a day or two, 24 to 48 hours, for just making sure that this patient a little bit more aggressively is not going to have these contractions. Stop the contractions, give the betamethasone. That way we know that this baby is not going to be delivered. We're going to get them in that steroid window so that at least we have those 12 to 20 to 24 hours that we can give at least 2 injections of the IM betamethasone, celestone. And usually what is happening in-house is that they're followed up by giving the moms nifedipine, okay, which is their most commonly wide use. It's a calcium channel blocker, but that's the wide use tocolytic is your calcium channel blocker nifedipine, okay, nifedipine. And that is to delay preterm delivery. It's worked wonders. It's been used now for like the last 12 years or so, and they're using it more and more. Magnesium sulfate was having tons of side effects, so new management is we don't keep them with magnesium sulfate for weeks and weeks. The most is a 24, 48 hours. We get them off of magnesium sulfate IV. We give them a PO, okay? And usually their PO is about 20 to 30 milligrams PO, pretty much every 8 hours. They might give it to them sometimes 10 milligrams every 4 to 6 hours. Sometimes it's 20 milligrams every 6 hours. And sometimes you'll have the 20 to 30 milligrams PO every 8 hours, depending on how well we can control the contractions, okay? So a little bit on tocolytic drug therapy. Since TURB is a tocolytic, magnesium sulfate, we said that it was we said that we use it in preterm labor as a tocolytic. But I have to highlight that magnesium sulfate is FDA approved as an anticonvulsant. So it is used in hypertension, okay, as an anticonvulsant. That is what it's FDA approved for. Like many other medications, we have been using a magnesium sulfate as a tocolytic, but because of all the side effects, now we're using it. Now we're doing the PO with nifedipine, and we're using magnesium sulfate for the mechanism of action, but a short term, just to 24 to 48 hours. Okay. And of course, once they're stabilized, they're going to go on PO nifedipine. So, tocolytic drug therapy, because I don't want to, I want to make sure that everybody goes over the tocolytic drug therapy. It's a classification of drugs, and it's used to inhibit contractions by relaxing the smooth muscle of the uterus. Okay? And that's what terbutaline will do, and that's what mag sulfate does. They're smooth muscle relaxers, but magnesium sulfate is FDA approved as an anticonvulsant. That's why we use it in hypertension. Okay? But we were using it for the mechanism of action. So tocolytic drug therapy is a classification of drugs used to inhibit contractions by relaxing the smooth muscle of the uterus. Okay. So in the hospital, of course, if they come in with preterm labor, we want to give them those tocolytics. Sometimes we'll do the TERB, sometimes they'll do the MAG, only for those 24 to 48 hours. Okay, and then they're going to continue on with a PO calcium channel blocker, nifedipine. Okay. Prevention, because I know this is what we do at the hospital, but prevention, and I have to mention prevention because that's the practice out in the field. If we have a mom that this is a history of preterm labor, and let's say she gets pregnant again, remember progesterone? They're going to be a little bit more assertive with that mom, and they're going to draw hormone levels of that mom, and they're going to draw progesterone, and they might give her, because she has a history of preterm labor, they might give her progesterone supplementation, because when progesterone is high, you won't get the preterm labor. Okay. So maybe they'll give her an IM form. Maybe they'll give her a gel form. Maybe they can give her a natural progesterone supplementation. Okay, and that has shown big success. That if mom's progesterone is high, she won't go into preterm labor. The uterus won't start to contract before it needs to. Okay. Okay. So that leads us to hypertension and pregnancy. Now, I want to say before the classification of hypertensive states of pregnancy and how we classify. If there is no baseline available, let's say mom comes in and it's a late prenatal care patient, and there is no baseline available, we're going to say that anything above 140/90 is high blood pressure. And we even want, these moms lower, just like the American Heart Association wants, patients now in the 130s and in the 80s. But your book still has, you could still give mama a chance. But if we have no baseline and they're like right at that 140/90, then that becomes the blood pressure that you have of baseline if you don't have anything else to go by. And we classify hypertensive states as chronic, and these are, we're going to go through them, okay? So these are hypertension or proteinuria or both, okay? In pregnant women that is present before pregnancy. So these were already hypertensive patients, okay? Or was diagnosed before 20 weeks, okay? So these are your chronic hypertensives. These are your hypertensive patients, okay? And yes, if you're hypertensive before you got pregnant, you're going to persist after 6 weeks postpartum, okay? this doesn't resolve 12 weeks postpartum. Okay. Now, if you are gestational hypertension, okay, you are now pregnant and you have acquired gestational hypertension. And this is that development of mild hypertension after 20 weeks gestation when you were previously normal, okay, and you didn't, and this is without proteinuria. Okay. There are some stats that say that if a patient is diagnosed with gestational diabetes before she was 35 weeks, she is more likely to progress to a preeclampsia, which higher blood pressure readings with the symptoms. That's more statistics of what we're seeing. Okay, so this is development. Gestational is development of mild hypertension after 20 weeks when she was previously normal, okay, without proteinuria. That's why it's called gestational. It's acquired now in pregnancy. The lab values are not abnormal, okay, so there's no abnormal lab values. And usually the blood pressure returns to normal by 6 weeks postpartum. But then, if it does not, okay, and this is again general, all of these hypertensions and pregnancies are general happening after 36 weeks when that blood volume is double. Then there could be some mild preeclampsia. Okay. So you're starting to have features already, how your book describes it as having severe features, okay? Some without severe features and some with severe features. So your mild preeclampsia is without those severe features, okay? And what are those severe, without severe features? Well, there is no baseline again. We use 140/90. And then that's also taken to make sure that patient is actually hypertensive. Make sure that it's taken in 2 occasions, laying down, relaxing for 15 minutes, laying down on 2 occasions, 6 hours apart. Okay. And if that's the case, and then there's no baseline, we take the numbers of 140/90. Characterized by increased blood pressure, now proteinuria +1 or more on dipstick, and edema, usually the extremities, a little bit on the face and the extremities. Okay, that's your mild preeclampsia, and that's the one that your book has without the severe features. Now, your severe preeclampsia is the one that your book is calling with severe features. Okay, this is characterized by the blood pressure. Now, if it's 160/110, this is where we have to draw the line and say this is severe preeclampsia. This has severe features involved. Okay, or more on 2 occasions, again, laying down, okay, 6 hours apart. Now, the severe features, here we go. Proteinuria is +3 or more on a dipstick. Now she's got the features. Now she's got the headache, the blurred vision, scotomata. You will see this in the charts a lot. Scotomata, Scotomata. These are like 4th of July in your eyeballs, okay? Pitting edema, nausea and vomiting, epigastric pain, okay? That increase in severe creatinine, okay, more than 1.2 milligrams per deciliter. So that is increased serum creatinine. Okay. Mom comes in with severe preeclampsia. Yes. What is the management? Delivery. We are going to deliver this mom. Okay. Now, this is the mom that, of course, she will be on magnesium sulfate, as it is FDA approved as an anticonvulsant. Okay. She will be on magnesium sulfate. Okay. We have to control blood pressure in chronic hypertension or severe. So in the mild and in the severe, we have to control that blood pressure because we want to prevent her from stroking. Okay. And also characterized by in the severe preeclampsia is ankylosing, and that's just a pulsed motion of the foot after flexion. Okay, you want to have sharp, deep tendon reflexes. And if that clonus continues, then that is not good, especially if mom is on magnesium sulfate. Okay, if she's on magnesium sulfate, there is box 21.10 in your book. Okay, 21.10 in your book. It is on page, and I will give you the page in just a minute here, so that you look up magnesium sulfate. Love these pictures. 21.9 has the ankle clonus, and 21.10, and there's a box, this is 21.10 on chapter 21, that has a page 554, talks about the nursing care based on the responsibility for pharmacology on magnesium sulfate. Okay, love this book. Page 554, book 20, the box 21.10 talks about magnesium sulfate. Anytime that your mom is on magnesium sulfate, whether it be 24 to 48 hours, or whether it will be to control that severe, that blood pressure, okay, for hypertension, whether mom is in mild preeclampsia, severe preeclampsia, her blood pressures are increasing, and we're going to put mom on magnesium sulfate as an anticonvulsant. You've got to monitor 3 things every hour on the hour for magnesium sulfate when they're on it. Respiratory rate has to be more than 12. Urinary output needs to be more than 30 cc's an hour, and deep tendon reflexes need to be positive. Okay, usually when they're on magnesium sulfate, you want to do biceps reflex. Okay, positive. You do not want to see clonus. Okay, you do not want to see clonus. It has to be a positive deep tendon reflexes. And those 3, respiratory rate, urine output, and DTRs, those 3 need to be assessed every hour on the hour when mom is on magnesium sulfate. So we talked about how severe preeclampsia, we've got to get mom stable and we got to get her delivered. Also in the hospital, this becomes an emergency, and there are algorithms in the hospitals that we have that have preeclampsia and other hypertensive disorders. If they come in, their blood pressures are, 110, more than 110, 160 over 110. I'm just thinking of diastolic, systolic, so 160 over 110, then they will give them IV antihypertensives. And your most famous one in OB is still your IV hydralazine that is given. Okay, your IV labetalol, which is beta blockers, work really well, and that's another med to look up. Labetalol, Labetalol, or IV hydralazine. Okay, so still, if these blood pressures are more than 160 over 110, then they're going to stabilize them because it's an emergency and get them delivered. We're going to give them IV hydralazine or IV labetalol. And then, of course, if we can't get an IV access right away, then nifedipine is commonly prescribed for mild to moderate hypertension in pregnancy. And then usually, the initial dose is 10, and it could be repeated at 20-minute intervals for a maximum of 5 doses. So I'm just gave you a little scenario of, what is done in-house, because this is severe. We can't have this blood pressure happening. This mom needs to be delivered, but we have to stabilize her. And how we stabilize her is we're going to give her the mag sulfate as an anticonvulsant, and we're going to give either IV hydralazine or the IV labetalol, beta blocker, okay? IV labetalol, IV hydralazine, okay, to stabilize her. And again, we can repeat, we can give, for example, 5 to 10 milligrams over a minute or 2. We can repeat the blood pressure in 20 minutes. And if it's elevated, we can give her again IV hydralazine, 10 milligrams, again, we can repeat in 20 minutes. And then if it's elevated, then we can switch over to IV labetalol, 20 milligrams. And then we can repeat in 10 minutes, okay? And at that point, you're obtaining an anesthesia consult to get mom in the back to get this baby delivered. So just want to let you know that this is an emergency. You need to stabilize mom to get this mom delivered. And the hospitals, the healthcare providers don't play with high blood pressure. Okay, severe vasoconstriction for this baby in utero. We need to stabilize and get this baby out. Okay, so that was an example that I did of what we do in-house if the blood pressures are more than 160 over 110. The drugs of choice for these moms to lower their blood pressures is IV labetalol, okay, Labetalol, beta blocker, or IV hydralazine. And I just gave an example of a cascade of what it is that we do. Okay, so, and usually if you start with the IV beta blocker and it doesn't work, then we end up giving her hydralazine, and vice versa. If we start with hydralazine and it doesn't work or it doesn't lower it as fast, then we will give labetalol. Okay, the two work wonders, and they do work because we have to take mom to the back to get her delivered. And then again, if we don't have any IV access, PO nifedipine works well, very well on pregnancy. Okay, so I wanted to give you those examples because this is an emergency that we need to get mom delivered. And then we go into eclampsia. It's characterized by convulsions. Okay. Severe edema is so acute that a grand mal seizure happens. Okay. And eclampsia should never happen. You should never see it. We should be able to control this hypertension to get mom back, to get her delivered, and never ever get to the point where she's going to be comatose or she is going to start having convulsions. Okay, never should be the case. Okay, and then this will seem like a repetition, but again, treating preeclampsia. Okay, because at this point, if she starts with these blood pressures, okay, then of course, whether it's mild or whether it's severe without the severe features or with the severe features, it's preeclampsia. Okay. So how do we do with the management? At home, we can check fetal movement, a bed rest. She could check her blood pressure. She could do a urinalysis daily. She'll have somebody take her, to get her biweekly non-stress test, or if she could still drive, take her some mamas as they get into their third trimester, their seat belt, the steering wheel's too close to their bellies. We'll have somebody driving them around, especially if they're getting hypertensive. They don't want to stress out more in the wheel, so they could get biweekly non-stress test, 24-hour urine collection, and their best position again for increasing uteroplacental blood flow because they are having high blood pressure is low lateral recumbent position. Okay, that is left lateral recumbent position. That is to increase uteroplacental blood flow. Okay. Then in the hospital, okay, we're going to do biophysical profiles again, BPP for biophysical profiles, non-stress test, 24-hour urine collection for protein, for creatinine. Again, your anticonvulsant. So we're going to give the magnesium sulfate, your anticonvulsant. Okay. And of course, we're going to check for DTRs, respiratory rate and urine output. Okay. And then your antihypertensives. Now, I will tell you that your most famous ones right now in-house is your labetalol, your beta blocker. Okay, is your most famous one, and your PO nifedipine. Okay, your PO nifedipine is your antihypertensives. And again, when they first come in, to control it, if it's 160 over 110, exactly what I just told you. We're going to do the IV hydralazine or the IV labetalol, okay, to bring that blood pressure down and get mom delivered. Now, managing eclampsia, I know you've had seizure management in block 2, but it's all about seizure management, okay? Managing eclampsia, magnesium sulfate, your safety precautions, okay? Usually if it's an eclamptic seizure, it really tends to be self-limiting. Usually there's no drug that's needed to terminate the seizure if it's an eclamptic seizure, okay? Usually it's very self-limiting. But again, you shouldn't see this because we manage hypertension. That's why we aggressively manage hypertension. There's cascades because it truly does become an emergency. If we start to see the levels, they come in with the levels of 160 over 110. We're going to manage it. We're going to get this mom delivered. Okay. And again, a little bit on what's happening with the etiology of preeclampsia. Okay, you've got the increase, you've got the vasospasms, you've got that decrease for sure, lack of, oxygenation. Okay, decrease in oxygenation, so the lack of to the baby, decreased placental perfusion. You've got endothelial cell activation, vasoconstriction. You've got the decreased organ perfusion. Okay, this is a great algorithm as you're studying. Another one as you're studying. And then you've got gestational diabetes, okay? Carbohydrate intolerance with the onset first recognized during pregnancy. This, again, it complicates about 3 to 9% of all pregnancies. Again, the ideal blood glucose is about 60 to about 120. Risk factors, over the age of 25, obesity, family history of diabetes, sometimes cultures. Latinos, African Americans, Asians, tend to be the cultural group with more of this acquired diabetes now in pregnancy, gestational diabetes. Some maternal risks is polyhydramnios, too much amniotic fluid, hyperglycemia, has dystocia, okay? It's a difficult delivery, okay, difficult labor. Some fetal also can bring in some maternal risks with, again, pregnancy-induced hypertension that mom didn't have before, but now it's induced by this pregnancy, okay? And a large placenta could be the maternal risks. The fetal risk, sometimes it'll be a fetal demise due to DKA or UTI, okay, diabetic ketoacidosis or a UTI. It could be macrosomia. It could be a big, juicy baby because of all the sugar in the blood as this baby is developing in utero. It could be macrosomia, so it could be big, juicy babies. Okay, and this causes this macrosomia because the babies are so big can cause perineal lacerations, can cause mom to have an episiotomy, a C-section, shoulder dystocia. Okay, and then intrauterine growth restriction. Okay. So this could be because of maternal hypotension. This could be small for gestational age babies, okay, smaller than they're supposed to be. And this is because of the vasoconstriction of the maternal and placental blood vessels, okay? Also with more of the fetal risk, it could be respiratory distress syndrome, it could be prematurity, neural tube defects, and diabetes does carry a high risk for congenital anomalies. Okay, high sugar levels as this baby is developing in utero does carry a high risk for congenital anomalies. And then this is why we screen. Okay, these moms, we talked about the screening and high normal antepartum. So we screen them first. They're not fasting. They drink and we draw their blood an hour later, and that's your 50 gram. This is your glucose tolerance test that you studied in normal antepartum. 50 gram of random glucola testing at about 24 to 28 weeks. You don't have to be fasting, and they drink and their blood gets drawn an hour later. Then the glucose values, if they're between 135 and 140, okay, so they should be less than 130 milligrams per deciliter. It's a positive screen. And if it's a positive screen, then they're followed up with a 3-hour oral glucose tolerance test, okay, which they have to be fasting, and we obtain their fasting glucose, and then that I'm explaining the 3-hour glucose tolerance test. First, we get a fasting glucose that's obtained, okay. Then mamas will drink 100 grams of glucola, okay. Our pregnant patient will drink 100 grams of glucola, okay. And then if 2 or more of the values are high, and then of course we draw their values 1 hour, at 2 hours, and at 3 hours. Okay, and the gestational diabetes is diagnosed if 2 or more of these values are increased. Okay, if when we draw their blood 1 hour, 2 hours, 3 hours, if 2 or more of these values are increased, then we will say, then they'll get the diagnosis of gestational diabetes. And our management for these moms, we want to put them on a diabetic diet, okay, glucose monitoring, home office visits, home or prenatal office visits sometimes. They could do their glucose monitoring at home or in their prenatal office visits. Glyburide tends to work really well, okay, their management for oral or insulin management. Glyburide tends to work really well 30 minutes before their meals, okay, or oral or insulin management for the moms, okay. And of course, we want to make sure that we evaluate fetal well-being, okay, non-stress test, and we educate in the signs and symptoms of hypoglycemia and hyperglycemia, okay, with the moms. And some key points before we wrap up this high-risk antepartum lecture: lack of maternal glycemic control before conception and in the first trimester of pregnancy may be responsible for fetal congenital malformations, anomalies. Maternal insulin requirements do increase as a pregnancy progresses and may quadruple by the time by term as a result of insulin resistance created by the hormones. At birth, the levels decrease dramatically, so breastfeeding will affect the insulin needs. So the sliding scale is going to be different if she's on insulin after she delivers postpartum. And poor glycemic control before and during pregnancy can lead to the complications: miscarriage, infection, dystocia, that's the difficult labor, and that's because it's caused by that fetal macrosomia, which is that big juicy baby. Okay, you can see some changes in insulin during pregnancy. Careful monitoring, okay, when necessary. Diet counseling, absolutely. We send them to diet counseling, okay, so now they can eat a healthier diet. And because gestational diabetes is asymptomatic, many women do undergo. That's why in prenatals, they undergo a routine screening during pregnancy. Thank you for listening. This concludes the high-risk antepartum lecture.